Good morning, everyone. Welcome to today's presentation. I'm Dr. Asim Hassin, and I'll be guiding you through the management of major burns. This is a critical topic, and I'm glad you're here to learn more about it. Over the next few slides, we'll cover key principles, treatment strategies, and important considerations when dealing with major burn injuries. Let's get started. Let's take a closer look at this scenario. We have a 45-year-old man who was involved in a house fire, and he presents with partial thickness burns over his chest, abdomen, and both arms. His estimated total body surface area burn is 28%, and importantly, he's hemodynamically stable. Now, the key question here is, which feature makes this a major burn that requires ICU management? Looking at the options, the most relevant point is the size of the burn. Specifically, burns involving more than 20% of the TBSA in adults. This is critical because burns exceeding this threshold often lead to significant physiological stress, fluid shifts, and risk of complications that necessitate intensive care. Other options, like partial thickness burns only or burns over 10% TBSA, are important considerations, but may not automatically require ICU management unless other factors are present. Isolated limb burns, or the absence of inhalational injury, also influence the severity, but are less central when we're focusing on overall burn size. So, the most important concept here is that burns involving more than 20% of the TBSA in adults, such as this case with 28%, are classified as major burns and typically require ICU-level care for proper management and monitoring. This underscores how the extent of the burn directly impacts the level of care needed. All right, let's look at the correct answer here, which is A when we consider burns in adults. The key point is that if the burn covers more than 20% of the total body surface area, or TBSA, it is classified as a major burn. And this classification holds true regardless of how stable the patient appears initially. So, even if someone looks stable at first, burns over 20% TBSA require ICU-level care because of the potential for complications and the need for intensive management. This emphasizes the importance of assessing the extent of the burn accurately and recognizing when a patient needs specialized care, which ties into our overall focus on appropriate burn management and escalation of care when necessary. All right, let's take a closer look at this scenario. We have a 60-year-old woman with significant burn injury, about 35% total body surface area, and she presents with facial burns, soot in her mouth, a hoarse voice, and agitation. These signs suggest airway compromise, which is a critical concern in burn patients. Now the question asks, what is the most important immediate management step? Looking at the options, we have high-dose IV opioids, large-volume IV fluids, early endotracheal intubation, broad-spectrum antibiotics, and escherotomy. While fluid resuscitation is vital in burn management, especially for large burns, in this particular case, airway management takes precedence. The soot in her mouth and hoarse voice point toward possible airway edema or inhalation injury, which can rapidly progress to airway obstruction. Therefore, the most urgent and life-saving step here is to secure the airway early, meaning early endotracheal intubation, to prevent airway compromise. This step can be life-saving and should be prioritized over other interventions. So the correct answer is C, early endotracheal intubation. This highlights the importance of airway assessment and management in burn patients, especially when inhalation injury signs are present, aligning with our overall focus on prompt, effective emergency care. Let's focus on the correct answer here, which is C. The key point to remember is that airway protection is always the top priority in these situations. Inhalational injury can cause rapid swelling or edema of the airway, which can quickly compromise breathing. That's why early intubation is so crucial. It can save lives by securing the airway before swelling makes it impossible to breathe. Throughout this presentation, we've emphasized how critical it is to act swiftly and prioritize airway management in burn or inhalation injuries. This slide underscores that immediate intervention can make all the difference in patient outcomes. So let's look at this question about initial fluid resuscitation for a burn patient. We have a 70 kg man with 40% total body surface area burns who's been admitted to the ICU within an hour of injury. The key here is understanding the most appropriate fluid strategy to support his circulation and prevent shock. Now, the options include different formulas and approaches. The most common and evidence-based method is using the Parkland formula, which recommends administering 4 ml of Ringer's lactate per kilogram of body weight per percent TBSA burned. This amount is given over the first 24 hours, with half of it delivered in the first 8 hours and the rest over the following 16 hours. This approach targets the early phase where capillary leak is most significant, and fluid resuscitation is critical to maintain perfusion and organ function. The other options, like fixed boluses or albumin only in the first 24 hours, aren't aligned with current best practices for initial burn management. So the correct answer here is B, 4 ml per kg per percent TBSA of Ringer's lactate. It's the most tailored and evidence-based strategy for this patient, ensuring he gets adequate volume replacement early on. This concept ties into the broader theme of effective burn management, using precise calculations to optimize outcomes and prevent complications. The correct answer here is B now. Let's talk through the explanation. The Parkland formula is a key tool we use to estimate fluid resuscitation needs in burn patients. It's calculated as 4 milliliters per kilogram of body weight multiplied by the percentage of total body surface area burned. We typically administer this calculated volume of Ringer's lactate solution. Importantly, we split this total volume into 2 phases. 50% is given within the first 8 hours after the burn injury, and the remaining 50% is infused over the next 16 hours. This approach helps ensure adequate tissue perfusion and prevents complications like shock. Remember, the goal here is to tailor fluid therapy based on the severity of the burn, which makes the Parkland formula a critical part of initial management. Connecting this to our overall theme, proper fluid resuscitation is vital to improving outcomes in burn patients, and understanding this timing and calculation is fundamental. All right, let's look at this question. 6 hours after admission, we've given the burn patient fluids, but they're still tachycardic. The key here is to find out which parameter best reflects whether we've achieved adequate fluid resuscitation. Now, the options are central venous pressure, mean arterial pressure, urine output, lactate alone, and heart rate normalization. Central venous pressure, or CVP, can be helpful, but it's not always the most reliable indicator on its own. Mean arterial pressure, or MAP, is important, but again, it doesn't give us the full picture of perfusion and volume status. Urine output is a very practical and direct measure of how well the kidneys are being perfused, which in turn reflects the adequacy of fluid resuscitation. Lactate levels can indicate tissue hypoperfusion, but lactate can be influenced by many factors and may not change immediately. And finally, heart rate normalization. While a decreasing heart rate can be a good sign, it can also be affected by pain, anxiety, or other factors, not just fluid status. So, in this case, the best parameter to reflect adequate fluid resuscitation is actually urine output. It's a real-time, straightforward indicator of perfusion and volume status. This ties into our overall theme of monitoring and adjusting resuscitation efforts based on clinical parameters. Keeping an eye on urine output helps us ensure we're providing enough fluids without overdoing it. All right, let's look at the correct answer, which is C now. When we're monitoring a patient's fluid status, one of the most reliable bedside markers is urine output. Specifically, we aim for a urine output of at least 0.5 milliliters per kilogram per hour in most cases. However, if the patient has rhabdomyolysis, that target increases to at least 1 milliliter per kilogram per hour. This helps us ensure adequate kidney perfusion and fluid balance. So, overall, urine output is a simple yet very effective way to assess whether our interventions are working and the patient is stable. Keeping an eye on this parameter is crucial for guiding ongoing management. Let's take a closer look at this scenario. We have a patient with circumferential full-thickness burns on the forearm. Now, what are the key signs we're seeing? Severe pain, which might seem surprising given the full-thickness burns, but it can still be present initially. More critically, we notice tense swelling and reduced capillary refill, indicating compromised circulation. The falling SpO2 despite ventilation suggests that systemic effects are worsening, possibly due to ischemia or compartment syndrome. This combination of signs, especially the tense swelling and reduced perfusion, points towards a serious complication called compartment syndrome. It's a condition where increased pressure within the fascial compartments impairs blood flow, risking tissue necrosis if not promptly addressed. So, what's the most appropriate next step? Among the options, starting antibiotics or increasing the opioid dose wouldn't address the immediate concern of compartment pressure. Elevating the limb might help a little, but won't resolve the underlying issue. Applying a compression dressing would actually worsen the situation by increasing pressure. The most urgent and effective intervention here is an escherotomy. This surgical procedure relieves the pressure, restores circulation, and prevents tissue death. Connecting this to our overall theme, early recognition and prompt management of burn complications, is crucial. Timely intervention can make a significant difference in patient outcomes. The correct answer here is E now. Let's talk about why. Circumferential burns, which involve the entire circumference of a limb or the chest, can be particularly dangerous. They can cause compartment syndrome, where pressure builds up within the muscle compartments, and this can cut off blood flow and nerve function. Additionally, these burns can restrict ventilation if they occur around the chest, making it harder for the patient to breathe properly. The key point is that in these situations, an urgent escherotomy is often necessary. This surgical procedure cuts through the burn eschar to relieve pressure, restore circulation, and improve ventilation. It's a life-saving intervention that can prevent severe complications. So, recognizing circumferential burns and acting promptly with an escherotomy is critical in managing these patients effectively and ensuring their survival. This ties into the overall theme of rapid assessment and intervention in burn care. All right, let's look at this scenario. It's day 2 post-burn, and the patient is actually afebrile, with stable vital signs and clean wounds. Now the question is, what's the best antibiotic strategy here? Option A suggests starting broad-spectrum antibiotics prophylactically. But generally, routine prophylactic antibiotics are not recommended in burns unless there's clear evidence of infection. Overusing antibiotics can lead to resistance and other complications. Option B proposes no antibiotics unless an infection is suspected. This aligns with current guidelines, emphasizing careful monitoring and reserving antibiotics for when there's actual evidence of infection. Option C recommends using only topical antibiotics. While topical agents are useful for local wound management, systemic antibiotics aren't typically needed unless there's an infection that can't be controlled locally. Option D suggests routine antifungals. But unless there's a specific fungal infection, routine antifungal use isn't indicated, especially in the early post-burn period. And finally, Option E considers antibiotics only after skin grafting. But in this case, since the wounds are clean and the patient is stable, unnecessary antibiotics before grafting aren't justified. So the key takeaway here is that in the absence of signs of infection, the most appropriate approach is to avoid unnecessary antibiotics. Instead, careful clinical monitoring is essential to catch any developing infections early. This approach helps prevent antibiotic resistance and promotes better overall outcomes. The correct answer here is B now. Let's talk through why that is. Prophylactic systemic antibiotics, or preventive antibiotics given to stop an infection before it happens, are actually not recommended in this scenario. Instead, the best approach is to treat only when there are clear signs of infection or if an infection is suspected or confirmed. This is an important point because unnecessary use of antibiotics can lead to resistance and other issues. So, the key takeaway is to avoid routine prophylactic antibiotics and focus on targeted treatment when there's an actual infection. This approach aligns with the overall theme of responsible antibiotic use and best practices in managing infections effectively. Now, let's consider the options for this ventilated burn patient with 45% TBSA who is hemodynamically stable at 12 hours post-injury. The key here is to identify the most appropriate nutritional strategy to support healing and recovery. Option A suggests keeping the patient NPO for 5 days, but delaying nutrition this long can be detrimental, especially in burn patients who have high metabolic demands. Option B refers to total parenteral nutrition, which is an option if enteral feeding isn't tolerated, but generally, early enteral feeding is preferred when possible. Option C is oral feeding only, but in a ventilated patient, oral intake isn't feasible at this stage. Option D, early enteral feeding within 6 to 12 hours, is considered the best practice here. It not only helps maintain gut integrity, but also reduces the risk of infections and supports immune function. Finally, option E involves a high-fat ketogenic diet, which isn't typically used in the acute burn phase. So, connecting these points, the most optimal approach in this scenario is early enteral feeding within the first 6 to 12 hours after injury. This strategy aligns with current guidelines and helps promote better outcomes for burn patients. The correct answer here is D now. Let's break down why early enteral nutrition is so beneficial. When we start feeding patients early through the gut, it actually helps reduce gut translocation, which means fewer bacteria or toxins pass from the gut into the bloodstream. This reduction is crucial because it lowers the risk of infections and ultimately decreases mortality rates. Additionally, early enteral nutrition helps attenuate hypermetabolism, which is the body's exaggerated metabolic response to injury or illness. By supporting the gut and the overall metabolic state, we can improve patient outcomes and promote faster recovery. So, integrating early enteral nutrition into our management strategies aligns perfectly with our goal of optimizing patient care. Let's analyze this question carefully. A severely burned patient develops hyperglycemia, muscle wasting, and persistent tachycardia, even though sedation is adequate. These signs suggest a hypermetabolic state that goes beyond simple fluid loss or infection. The key here is to understand what underlying process causes these specific symptoms in burn patients. Among the options, hypermetabolism induced by burns leads to increased energy expenditure, muscle catabolism, and elevated heart rates. This hypermetabolic response is primarily driven by a complex hormonal cascade, including increased catecholamines, cortisol, and other stress mediators. It explains why the patient experiences hyperglycemia due to insulin resistance, muscle wasting from protein breakdown, and persistent tachycardia as part of the body's heightened metabolic state. So, when you see these signs together, hyperglycemia, muscle wasting, and tachycardia, think of the burn-induced hypermetabolic state. This is a distinct and characteristic response to severe burns, and it's crucial to recognize it to manage these patients effectively. The correct answer here is C now. Let's talk about why that is. Major burns, as you might expect, cause a significant physiological response. Specifically, they trigger a profound hypermetabolic and catabolic state that can last for weeks. This means the body's energy expenditure skyrockets, and there's rapid breakdown of tissues, especially muscle. Understanding this response is crucial because it impacts how we manage burn patients and their recovery. Recognizing the duration and severity of this metabolic shift helps us tailor nutritional and medical interventions to improve outcomes. So, this point ties directly into our overall theme of understanding the body's response to severe injury and how to support it effectively. When we talk about major burns in adults, there are several key criteria to keep in mind. A burn is considered major if it involves 20% or more of the total body surface area, or TBSA. This indicates a significant amount of skin is affected, which can lead to serious complications. Additionally, any inhalational injury, such as damage to the respiratory tract from inhaling smoke or toxic fumes, also classifies a burn as major. This is because inhalational injuries can compromise breathing and require urgent intervention. Electrical or chemical burns are also categorized as major burns due to their potential for deep tissue damage and complex treatment needs. Furthermore, burns involving critical areas like the face, hands, or perineum are considered major because of their impact on function and appearance, and the higher risk of complications. Lastly, circumferential burns, which encircle a limb or the chest, can restrict blood flow or breathing, making them particularly urgent. All these factors highlight the importance of thoroughly assessing burn injuries to determine if they are major, as this guides the urgency and type of treatment needed. Remember, recognizing these key features helps us prioritize care and improve outcomes for our patients. Let's talk about the primary survey, following the ABCDE approach, which is essential in managing major burns. First, A stands for airway, and if you suspect inhalation injury, early intubation is crucial. This helps secure the airway and prevent airway compromise later on. Moving to B, administer 100% oxygen right away because burn patients are at risk for carbon monoxide poisoning, which can be deadly if not treated promptly. For C, ensure large-bore IV access, ideally avoiding burned skin if you can, to facilitate rapid fluid resuscitation and medication delivery. Next, D involves assessing the patient's Glasgow Coma Scale and considering carbon monoxide intoxication, since altered mental status can be a sign of hypoxia or poisoning. Finally, E emphasizes full exposure to assess the extent of burns and controlling the patient's temperature, as burn injuries can lead to hypothermia. These steps are fundamental to the overall management of major burns, ensuring we address airway, breathing, circulation, neurological status, and environmental factors systematically for the best patient outcomes. Let's talk about fluid resuscitation, which is a critical part of managing major burns. The classic approach here is the Parkland formula, which recommends administering 4 milliliters of Ringer's lactate per kilogram of body weight per percentage of total body surface area burned. So, for example, if someone weighs 70 kilograms and has 30% TBSA burns, you'd give about 8,400 ml in the first 24 hours. But it's important to remember, we don't just follow the formula blindly. We need to titrate the fluids based on the patient's response, especially their urine output. Urine output is a real-time indicator of whether we're providing enough fluids, not just sticking to the initial calculation. Another key point is to avoid fluid overload, which can lead to complications like abdominal compartment syndrome. This is a serious condition where increased pressure within the abdomen impairs blood flow and organ function. So, close monitoring and adjusting fluids accordingly are essential to prevent that. In summary, fluid resuscitation in major burns involves using the Parkland formula as a starting point, but always tailoring it to the patient's response, with urine output as our guide, and being cautious to prevent overloading the patient. Let's start with airway and breathing management. In cases of major burns, securing the airway early is crucial. If there's any suspicion of inhalational injury, it's important to proceed with a bronchoscopy to assess the extent of airway damage. Always be vigilant for signs of ARDS or acute respiratory distress syndrome, which can develop as a complication. Recognizing these issues early allows for prompt intervention, which is vital in improving patient outcomes. Remember, effective airway and breathing management forms the foundation of treating major burns, supporting the overall goal of stabilizing the patient and preventing further complications. Let's talk about circulation and some critical interventions. Escherotomy is a key procedure we consider in cases of compartment syndrome, which can occur when swelling constricts blood flow. It's also important in ventilatory restriction situations, where chest wall swelling limits breathing. Monitoring plays a vital role here, so keeping an eye on lactate levels, urine output, or UOP, and the base deficit helps us assess tissue perfusion and overall metabolic status. These measures guide us in making timely decisions to ensure the patient's circulation is maintained and complications are minimized. Remember, managing major burns isn't just about skin. It's about supporting the entire circulatory and metabolic environment to promote healing and recovery. Let's talk about infection control in major burns. Burns create an immunocompromised state, meaning the body's defenses are weakened, which makes infection a serious concern. Interestingly, routine systemic antibiotics are not typically recommended for burn patients because they don't necessarily prevent infection and can lead to other issues like resistance. Instead, the focus is on early excision and grafting. Performing these procedures promptly helps reduce the risk of sepsis, which is a major cause of mortality in burn victims. Overall, effective management of major burns involves understanding these infection control principles to improve outcomes and prevent complications. Let's talk about nutrition and metabolism in burn management. Early enteral feeding is crucial, ideally within the first 6 to 12 hours after injury. This helps support the gut and reduces the risk of infections. We aim for high-protein, high-calorie feeds to meet the increased metabolic demands that burns create. It's important to provide enough nutrients to promote healing and prevent malnutrition. Tight glucose control is also essential. We want to avoid hypoglycemia, but at the same time, we need to manage blood sugar levels carefully because hyperglycemia can impair healing and increase infection risk. All these nutritional strategies are vital components of managing major burns. They support recovery, reduce complications, and help the body heal more efficiently. Now, let's discuss some of the common ICU complications we need to be vigilant about. First, sepsis is a major concern, as it can rapidly progress and lead to multi-organ failure if not identified and managed promptly. Next, acute respiratory distress syndrome, or ARDS, is another critical complication, characterized by severe inflammation and fluid buildup in the lungs, which requires careful ventilatory support. Then we have acute kidney injury, or AKI, which can occur due to sepsis, hypoperfusion, or nephrotoxic drugs. It's essential to monitor renal function closely. Rhabdomyolysis is also a concern, especially in trauma or immobilized patients, as muscle breakdown releases harmful substances that can damage the kidneys. Abdominal compartment syndrome is another serious issue. Increased pressure within the abdomen can compromise blood flow to vital organs, so keeping an eye on intra-abdominal pressure is vital. Stress ulcers are common in critically ill patients, often due to mucosal ischemia, so giving prophylactic proton pump inhibitors can help prevent gastrointestinal bleeding. Finally, when managing major burns, the focus shifts to fluid resuscitation, infection control, and supporting organ function. It's a complex process that requires a multidisciplinary approach. Recognizing and addressing these complications early is key to improving patient outcomes in the ICU. All right, let's go through some ICU PEARLS for managing major burns. First, if you notice a hoarse voice combined with soot around the mouth or nose, that's a red flag for potential airway compromise, and you should consider early intubation to secure the airway before it becomes an emergency situation. Next, when it comes to urine output, remember that it's the most reliable indicator of adequate perfusion and fluid resuscitation. Keeping a close eye on urine output helps us guide fluid management effectively. Moving on to escherotomy. If there's circumferential full-thickness burns causing constriction, don't delay imaging or intervention. Performing an escherotomy promptly can prevent vascular compromise and tissue necrosis. Also, it's important to note that burns are initially sterile, so routine antibiotics aren't necessary at first, but be vigilant for infection as the wound evolves. Lastly, nutrition plays a crucial role, not just as supportive care, but as a key part of the treatment itself. Providing adequate nutrition helps promote wound healing, immune function, and overall recovery. So always prioritize proper nutritional support in your burn management protocols. Thank you so much for your attention. I really appreciate you taking the time to go through this presentation with me. I hope you found the insights valuable and that they sparked some new ideas or perspectives. Remember, the key takeaways are about understanding the core concepts we've discussed and thinking about how they can be applied in your own context. If you have any questions or want to explore any of these points further, please don't hesitate to reach out. Thanks again for being such an engaged audience.